Adult onset epilepsy, the advantage of referring to an epileptologist, video EEG monitoring, and approach to care. That's next on Sutter Doc Talk.
Welcome to Sutter Doc Talk, a Sutter Health Network podcast hosted by physicians for physicians. Each episode features candid conversations with clinical insights and best practices. Now, today's topic.
Hi, my name is Dr. Ardeepsee Khan. I am a neurologist with Sutter Medical Group in Sacramento, California. I am board certified in neurology and clinical neurophysiology and specialize in the care of adult onset epilepsy. I will be talking to you today about adult onset epilepsy. So a few facts I think that are important to understand is how this disease affects our country and the world. 1 in 100 people will be affected by epilepsy. It is quoted that 50 million people worldwide suffer from epilepsy, and 70% of these people could be well controlled if they are diagnosed appropriately and treated appropriately. The age of onset for adult epilepsy is really any time. You do not have to have a prior childhood history, you do not have to have family history. And that seems to be the biggest thing that patients have a hard time grappling with. As our society ages, we are now starting to see more elderly with epilepsy, and that is probably our highest percentage of patients now coming to us that have new onset seizure disorders. The diagnosis of epilepsy has been laid out by the International League Against Epilepsy. And what they state is that 1 or more unprovoked seizures gives a 60% likelihood of another seizures within 10 years if there are certain criteria that we find with their diagnostic process, which usually includes EEG and MRI evaluation. So our goal is to find these patients early and treat them right away so that they don't suffer from another seizure that could affect their quality of life. 30 to 40% of patients with epilepsy are considered refractory. Now, if you're an optimist, that means that 2/3 of patients will do well if they're diagnosed properly. But what do we do with that 1/3? And that's what I'll be getting into as we move on. And just for information, refractory basically means failure of 2 adequately chosen and tolerated medications, either by themselves or in combination. So the advantage of utilizing an epileptologist, we focus on a good history, asking the right questions, getting to understand what exactly is being called a seizure. Are they true epileptic events? Are we dealing with non-epileptic events? Is there potentially a cardiac cause, an autonomic cause, a movement disorder instead, and sometimes even a combination of these? My next step usually is classifying. Do I think this patient may have a seizure onset that is generalized, or is it more focal? Because that could mandate how their treatment plan is laid out in the future. So this goes with, of course, taking the history, but also ordering the appropriate tests, which tend to usually be an EEG study. And we have 3 types of EEGs that we usually will utilize. A routine EEG study where we will often have the patients come in sleep deprived, and if we're able to have them undergo hyperventilation and photic stimulation to try to bring out some of the abnormal discharges that we are trying to look for. We often will do ambulatory EEG studies as well to see if we can capture a spell, or even just to review the data to find, once again, epileptiform discharges that might help us diagnose them better. And when things are even more complex, or we're having a hard time in classifying, or perhaps we're evaluating a patient for other potential treatments, we will then go to a video EEG study, which I will get into in a bit. In addition to the EEGs, we obviously do utilize neuroimaging. And today our practice tends to be utilizing the 3 Tesla magnet and using epilepsy protocol, which performs really fine slices through the brain, but particularly the temporal lobe, where 70% of focal seizures tend to arise from. We also utilize other advanced neuroimaging techniques such as functional MRI, PET scan with EEG, SPECT scan, and MEG scan. And these techniques we usually will use if we're trying to classify and evaluate a patient, possibly for surgical treatment. The other advantage of having an adult epileptologist is that they are fellowship trained in reading and interpreting the EEG data, the video EEG studies in particular, and also in managing their care and coming up with a treatment plan that will last them throughout their life. When it comes to therapies, we obviously will start out with anti-epileptic drugs, and this can be complex. We have to take under consideration the mechanism of actions, the potential side effect profiles, what medications can we use in combination, especially if they have other comorbidities, and what medications will be more suitable depending upon their state of life, whether they're elderly, whether they're female, that is of childbearing age. And so we take under consideration all of these factors when picking our medication. So a little bit about the video EEG study. These are typically elective admissions. We plan them out in our office. I will discuss the process with my patient. It's an elective admission, so we will obtain authorization. And once they're admitted, they are hooked up to the EEG, and we have a video camera attached to the machine, which essentially will hopefully capture what they actually do during a seizure. We have safety protocols in place, padding of the bed, padding of the floors. They have an IV in place in case we need to provide medication quickly to stop a prolonged seizure or whatever things that may arise. We also are monitoring their heart rate, we're monitoring their EKG rhythm, and their oxygenation status. Our goal is to capture seizures, or at least look at their background activity, which will help us classify their seizure disorder. We will do things that we call activation procedures. One of the main things that we will do is lower or discontinue their anti-epileptic drug therapy. We will also utilize techniques like sleep deprivation, hyperventilation, and photic stimulation, and we'll perform these different techniques several times through the day or during their stay. A typical stay is probably about 5 days, but it can extend longer if we have a goal in mind to capture seizures for surgical evaluation, and it may be less. We do leave it to the patient to help guide how long they're there and how comfortable they are staying, and that usually ends up being the best way for us to get the information that we need. Before they are discharged, we do start them back on medication so that they're safe to go home. I also use this as an opportunity to change medications and watch them while they're in the hospital to see if there are any adverse effects that we would be concerned about. Along with admitting the patient and seeing them on a daily basis, they are in our neuro observation unit, where we have highly trained RNs who know how to assess the patient when they do have a seizure. They are provided a push button if the patient is able to indicate that they are having a seizure, or for family members that might be staying with them. We also have our technicians that are on the floor that will help repair electrodes, perform the hyperventilation and photic stimulation activation procedures, and also help evaluate the patient when they are having a seizure. As a part of the admission, I will review their video EEG study on a daily basis. And then when I round, I'll discuss my findings and come up with a treatment strategy. I discuss it with the patient and their family, and that way we have a dialogue on their seizures, what I'm seeing, what they're seeing, and does this match? It also allows me to have develop a connection with the patient and their family. So if I do institute a treatment strategy, they are usually more likely to consider it and stick with it. Let's go into approach to treatment. Our goal is seizure freedom on monotherapy with the least amount of side effects, but really no side effects at all. And luckily in this day and age, we have a large arsenal of medications that are available to us with low side effects. A lot of the challenge is finding the right one, and also when to consider adding a second medication. So when we evaluate patients, if they don't meet our criteria of having seizure freedom after trial of 2 or even 3 anti-epileptic drugs, then we do discuss other treatment therapies, which may include surgical treatment or even neuromodulation. And on top of it, I also like to discuss the planning for the future. If I see a patient who is well controlled on a medication and they've been on it for 20, 30 years, it's my obligation to discuss with them, how is that medication going to affect them when they're 60 or 70 years old? What are the pitfalls that we might see? What issues may they have with bone density or neuropathy, which would affect their balance and perhaps lead to fractures? So I like to look at the patient as a whole and develop their treatment plan for the future, not just for now. We also will discuss when is it safe to remove medications. We may have patients that have been seizure-free for 2+ years. What are the advantages of that? What would that entail? How would that affect their quality of life, especially when it comes to work and driving and caring for their families? We also discuss what will happen if they're not controlled. What are their risks to their health? Potentially dying from SUDEP, which is sudden unexpected death in epilepsy, and those that are at higher risk for that occurring. There's also a good consideration for mental health. A lot of our patients do suffer from depression, anxiety, as comorbidities, and oftentimes we need to address those issues as well. How are they managing their seizure disorder? Are those factors being considered in their treatment plan? Sometimes certain anti-epileptic drugs can be utilized to treat their mental health issues and also their epilepsy, so that we can limit the burden of excessive numbers of medication. And also discussing when is it good to elicit a psychiatrist in their care, and also a therapist that kind of help guide them. Equally important is patient safety when it comes to living with epilepsy. Our obligation is to teach them what to look out for and what behaviors to consider as they live their life. And this includes medication compliance, engaging in certain drugs or alcohol consumption, their sleep schedule, their level of stress in their life, how to manage all of these so that they can have the best outcome. Driving is a hot topic with patients when it comes to epilepsy. Oftentimes we do have to suspend their driving privileges, but we do also want to educate that there is an opportunity to get that privilege back, that it's not a one and done. And it's a challenge to have the patients have enough confidence in us to tell us when they have a seizure. Sometimes they're concerned that they will lose their driving privilege and oftentimes won't be forthcoming. So having a dialogue and giving them that opportunity to discuss this with us in an open communication is very important. And then going back to long-term side effects with anti-epileptic drug therapy, this may include cognitive decline, whether it's being on medication for a long time or just getting older or having other conditions that they may develop as they age. This also includes disability from their seizure disorder, especially if they're not well controlled. And socioeconomic status. Certain patients may not be able to work, and all of these factors have a serious impact on their quality of life. As mentioned with anti-epileptic drug therapy, our goal is monotherapy, one drug to do it all. Our challenges do include the age of the patient. There are certain medications that they may not tolerate. So an elderly patient, I worry about hyponatremia, leukopenia. That can affect them more adversely. We worry about their ability to clear the medications, whether it's renally or through their hepatic system. So choosing the right medication can make all the difference, especially when they're also dealing with memory issues as they age and other medications they're on for other conditions. Gender, usually women of childbearing age, can be a particular challenge. Some of those challenges may be fertility. Some of those challenges are relieving misconceptions that they should not be on seizure treatment when trying to get pregnant or when they are pregnant, which medications are safe to use. Oftentimes they will come to me and they've already stopped all their medications and have had several seizures. And so how do we eliminate that myth and educate these women about planned pregnancies and utilizing our help when it comes to pregnancies? And on the flip side, preventing pregnancies. Which medications might be affected by birth control, or which birth control methods might be better for that patient? What's interesting in this area is that a lot of the anti-epileptic drugs are being utilized for other conditions which you may come across. For example, migraine treatment, headaches, treatment of fibromyalgia and other pain conditions, particularly neuropathy, back pain, and even depression, bipolar disorder, and other mental health issues. And so oftentimes these patients may be on these medications for different conditions, and that may not be the right fit for them. Side effects the patient may be experiencing will reduce their compliance. If they're not feeling good on it, they're not going to take it. And so finding a strategy of putting them on medication which is slow, and keeping an open communication with them to let us know if things are not going well so that we can quickly change their medication. If you're an optimist, then that means 2/3 of patients with adult epilepsy will be seizure-free on monotherapy. But what do we do with the remaining 1/3? So our first line of treatment is adding a second medication, if that works out. But I also start thinking about, well, if this doesn't work out, what am I going to do next? And then I start utilizing evaluations, which I had touched on before, video EEG studies, the more complex neuroimaging, such as functional MRI and PET scans. We also will introduce neuropsychologic testing to gather a baseline of their cognitive abilities and memory decline, and slowly start introducing other potential therapies, which include resective surgery, laser ablation surgery. If these surgical approaches are not going to work out for that particular patient, then we do have the neuromodulation devices, which includes the vagus nerve stimulator and the RNS, which is responsive neurostimulation. And currently, there's also the opportunity to utilize deep brain stimulation in treating these patients. When we do have a patient that we're starting to consider surgical evaluation, we do take a multidisciplinary approach. So once I obtain their data, I perform the video EEG and I obtain the imaging, I meet with my colleagues from all the disciplines, neurosurgery, other epileptologists, neuroradiology, and neuropsychology to discuss each individual case and each patient's unique issues. In addition to our multidisciplinary approach, we also utilize social workers to help us manage any issues with disability, taking time off from work, and other resources the patient or their family may need in moving forward. So in summary, when should you refer? National guidelines state that if a patient continues to have seizures after 1 year of medical therapy, they should be referred to an epilepsy center. However, a patient with seizure freedom on monotherapy with no side effects would also benefit from a consultation, mostly to plan for their future. Make sure that their AED or anti-epileptic drug is appropriate for them. What are potential long-term side effects that they may not be aware of? Identifying surgical candidates early so that they can be seizure-free earlier and longer. Education for women of childbearing age when it comes to planned pregnancies and preventing pregnancies. Behavior education, management of triggers, identifying associated comorbidities, addressing social challenges, and of course, planning for their future. I hope this talk was informative. Please remember, we're here to help you take care of your patients with epilepsy and utilize all our resources so that they can achieve the best quality of life possible.
Sutter Doc Talk is a production of the Sutter Health Marketing Department and is affiliated with the Sutter Health Network. Do you want more Doc Talk? Find all of our episodes online at sutterhealth.org/doctalk. That's DOCTALK. Talk to you next time.